Changing topic a little bit from what we've discussed earlier, but I wanted to spend some time today just going over vent basics, but also grounding it a little bit in physiology and also in some of the data and evidence that is used to inform our decision making. I think often in the ICU, we pick up bits and pieces of what to do and how to manage the vents, but we don't always have time in that fast-paced environment to sort of slow down and get a more foundational understanding. So that is my goal for today, and I hope that this is useful for you guys. I have no disclosures. And to just jump right in and get started, I don't really want to spend too much time on indications for ventilation. I think we all appreciate the main indications are respiratory failure or airway compromise, but what I wanted to highlight with this slide was the definition of respiratory failure that a lot of common ICU textbooks will use, and that is that it's not just failure of the lungs to meet the oxygenation or ventilation or metabolic needs of the patients, but it's actually the failure of the respiratory system. And so that's the lungs, but also the chest wall. That's also the abdomen pushing up on the lungs. And I have been trying to consciously reframe the way I think about pulmonary mechanics and the respiratory system to think about this. I think a really striking example of this actually is the birth of the modern ICU. There was a Danish physician named Dr. Ibsen who in the 1950s was working in Copenhagen and appreciated that iron lungs were not keeping polio patients alive. And it was he who first introduced positive pressure mechanical ventilation in an ICU setting, essentially because in his ORs, he knew that for his paralyzed patients, he was applying positive pressure and that was ventilating them, versus iron lungs, which were a negative pressure system of ventilation. And so for his polio patients, like their lungs were fine. They were either unable to protect their airway due to bulbar polio causing dysphagia, pooling of secretions, or they had spinal involvement and phrenic nerve paralysis, and then their diaphragms couldn't contract to initiate a breath. And so I think that's a pretty striking example of the fact that it's not always the lungs themselves that are failing. To then transition a little bit, I want to talk about some of the common modes that we use and flesh out in a little bit more detail some of the things that we may or may not realize that we're selecting when we're in the ICU. Some of the things we might set, but then we may not realize our RTs are setting some of the other variables, and I think it's important to be aware of what those are. In preparing this talk, I sort of pestered a lot of co-residents that I knew asking what might be helpful. And I think a common question that came up is there a mode of ventilation that is better? And really the question was, is volume or pressure better for patients? Or is there a certain subtype of patient that may benefit from one over the other? The short answer is no. Most of the data that I could find really doesn't suggest benefit of one over the other. What I've included here is a meta-analysis published in Chest in 2015. And this looked at 34 studies. There is a mix of randomized trials and observational data. And I'm sorry, I don't have the breakdown of each, but essentially they were comparing patients who were ventilated with a pressure control system versus a volume control system, measured a whole bunch of different variables, including pulmonary compliance, gas exchange, some hemodynamic parameters such as MAP and cardiac index, and also length of stay in the ICU and ICU mortality. And they really found no significant difference across those parameters. The only thing for which they found a significant difference was that for work of breathing, that seems to be slightly less in patients who are ventilated on pressure control systems. However, when they looked at their data a little more closely, they thought that this difference was largely explained by insufficient inspiratory flow rates on some of the volume controlled patients. And when they corrected for that difference, there was no longer a statistically significant difference in work of breathing between the groups. So really what this means, and I think what a lot of our attendings and fellows will tell us, is there's not necessarily a strong benefit of one over the other. And so really the best thing is to just pick the mode that the RTs know, that you know, and that gives you the best chance of really knowing how to optimize the vent and take care of your patient. Here at UW, it seems like the mode that is most commonly used is volume control. And I think that is just a stylistic thing and sort of picking different fellows' brains. It seems like from institution to institution, they may prefer one over the other. But again, no data to support one over the other. When we say assist control, that is referring to the fact that one, with control, the vent is going to deliver a breath to the patient at a rate that you set. And two, the assist piece means that the vent will also support the patient if the vent can tell that the patient is trying to take a breath. And so again, the mode that we most commonly use here within the UDEP system is volume control. And with this, we are delivering a set volume for each breath. And we, or the respiratory therapist, will also set several other parameters. I think we know this from putting in initial vent orders in the unit, but we're setting our rest rate, our PEEP, our FiO2. But some of the other things that also get set, which I don't know that we always appreciated, especially as interns, is that we do set flow. So the liters per minute of air that is going into the patient's lungs, we set both the rate of that and the pattern of how we deliver that flow. We set the trigger, as in we tell the vent, these are the things that you will pay attention to that is going to make you then deliver a breath. And we set the limits. What are the parameters that the vent cannot exceed? And if they do, alarms are going to go off. What I've included here on the right-hand side is a scaler for what your waveforms will look like if a patient is on volume assist. I know I historically have been kind of intimidated by actually looking at the forms on the vent, but I think if you spend a couple of minutes just looking at the curves, they make a lot of sense. And what is shown here again is a patient who is in a volume control mode. And if you look at the middle of the three figures, you can see volume is delivered at a constant rate for the entirety of the breath. And this patient is receiving flow in a square waveform, and I'll explain a little bit more about what that means in a minute. The reason also that you can tell that this is not a pressure control is that the pressure is not constant over the time of the breath. Pressure control is another mode that we do sometimes use. For pressure control, we are not setting the volume, rather we are setting a driving pressure that will be delivered on top of the PEEP for an amount of time that we set. And that amount of time that we set is called the I time, or the inspiratory time. So again, we set that driving pressure. How much pressure are we giving on top of PEEP? Usually we aim for a driving pressure of 15 or less if we can. We really don't want to get up past 15. 20 is where we think it's kind of scary. We set an inspiratory time. And usually when we're setting that inspiratory time, we're also thinking about the respiratory rate that we've set. For example, if we set a respiratory rate of 10, the vent is going to give one breath every 6 seconds. And so then when we set our inspiratory time, say we set it at 1 second, that means it's going to give that driving pressure for 1 second for the breath, and then there will be 5 seconds for a patient to exhale before the next breath is initiated. And so thinking about that I to E, that inspiratory to expiratory ratio, and how that is affected by the respiratory rate that you set can be really important in thinking about whether or not your patients are going to start retaining air and potentially auto-peeping. Some of the other parameters that we set, similarly to volume assist mode, we set the triggers. They are usually time-based, and flow or pressure-based. We set the limits, which is usually pressure in this mode. And again, we set the PEEP and FiO2. Again, I've included scalars for pressure control here on the right. And what you can appreciate here is that the pressure waveform is constant throughout the time of the breath. And you can see here that the volume delivery is not that constant slope the way it was in the previous slide. I think we are all fairly familiar with selecting appropriate tidal volumes for patients. And so I'm not going to delve into that too much. A couple of points that I wanted to make here. We know that the starting point is usually 6 to 8 mils per kg of predicted body weight. We know that we do a lower amount in ARDS because the ARDS-NET trials show us that when they looked at patients who were ventilated with low volumes at 4 to 6 mils per kg versus 12 mils per kg, they had a 9% reduction in mortality. But the other point that I wanted to make is that different studies have used different equations to actually generate the predicted body weight. And that can actually be significant. A 2015 review of various studies that were using different equations found that these different equations produced different numbers, which again will lead to different tidal volumes used. And that was even more noticeable if patients were shorter, if they were older, or if they were female. And so what ATS and CHEST recommends is using the equations that were used in the ARDS-NET trials, which is and the numbers from those equations are shown at right. So as I mentioned, flow is something that we set in the volume control mode. There are two things that we set with flow. One is the liters per minute of air that we're delivering to the patient. Machines can deliver a flow of usually about 60 to 120 liters per minute of air. Usually by default, we start at the low end of that, like 60 to 70 or so. We can also set the pattern with which we deliver that air. And there are two patterns that we can set on a volume control machine. In older machines, there was only one pattern, and that is a square waveform. So if you look at the left-handed diagram, the square waveform is depicted on the right-hand side of that diagram with the flow curve being at the bottom. And essentially when you start a breath, you're delivering a constant amount of flow, the same liters per minute throughout the entire breath until the breath terminates. And so you can see it creates a square shape when you graph it. That is not super physiologic. You can see I've included a curve on the right-hand side, which shows how flow looks in a patient taking a normal breath, which is much more sinusoidal. So you are just kind of shoving air into the patient's lungs the whole time. So newer machines have tried to essentially develop a more physiologic way to flow the air in. And so that is where you start to hear about the D cell waveforms. And so if you look at the left-handed side of that diagram, the flow curve on the bottom with that line that is descending throughout the breath represents your D cell waveform. So you deliver the highest amount of flow right at the beginning of the breath, and then it slows down throughout the breath. And that is a little bit more physiologic. You can kind of convince yourself if you compare that to the sinusoidal curve on the right. I think a couple of important things to appreciate about this is that if you're comparing the two different waveforms, the square waveform is going to deliver the breath faster than the D cell waveform. And this can become important in patients who are air hungering and who you really need to get that breath in quickly. If a patient is auto-peeping and they're not getting all of that air out from breath to breath, you might opt to do a square waveform because that's going to help get all the air in faster to then give them more time to exhale. And the other thing that I'll point out is that with a square waveform, you're going to result in a higher peak inspiratory pressure than you would with a D cell waveform. Of note, the plateau pressures will not change though. And I guess the other thing I would say too about that is that the D cell waveform, which is more physiologic, can sometimes just be more comfortable for the patient, again, because you're not slamming air at them as much. As I said, a trigger is something that you set in both modes. And this is telling the machine what do they pay attention to deliver the breath. And it's, I think, fairly intuitive that time is a trigger because we set a respiratory rate. But then there are also some things that are triggered by the patients that can have the vent then start to give a breath. And I think those are important to understand. For example, some machines can have what's called a flow trigger. And so the machine can detect changes in airflow. It's usually set around 1 to 4 liters per minute. And if the machine detects that change in flow, it will then give the breath, whether it's a volume control mode and it gives that volume, or a pressure control mode and it starts giving that driving pressure. This is important to recognize because sometimes if you set your flow threshold on the lower side, the machine can actually be pretty sensitive and pick up things like cardiac hypercontractility, the patient moving, you playing around with the tube. It can pick up those things as changes in flow and actually deliver a breath, even if the patient wasn't in fact taking a breath in. And so that can be bad because you don't want to be inflating the patient's lungs when they're not taking a breath. That again could lead to breath stacking. So if you do appreciate that happening, you can switch to a pressure trigger. And for this, the patient needs to get to an end expiratory pressure that you set on the vent. It's usually somewhere in the ballpark of like 1 to 4. And so that's getting below the PEEP typically that you've set. And if they get to that end expiratory pressure, the machine will then generate a breath. And so that's what's demonstrated here in these scalars on the right. If you look at the pressure waveform, which is the middle line, you see it running horizontally at the PEEP that the machine is set. And then the patient actually initiates the breath. And you know this because when patients are breathing on their own, they are generating negative intrathoracic pressure, right? Our lungs usually kind of work as a vacuum. And so you see that pressure drop, it gets down to whatever the trigger is, and then the machine delivers the breath. And you can see that with the next breath, actually, there's no negative deflection in the pressure curve. And that's because the patient did not initiate that breath. The machine initiated that breath. There are different studies that have looked at what triggers might be better for patients in terms of, number of days on vents, mortality, ICU length of stay. It's not totally clear to me if one is better than the other for outcomes. And so it seems, as far as I can tell from reading, it's just more about which does the patient seem to be more comfortable with and be able to get breaths with when they need them. Some of the older studies that I looked at didn't really show differences between flow and pressure triggers. There was a more recent study in 2015 where they compared patients in a flow trigger group versus a pressure trigger group, and the patients who used flow triggers did get off the vent significantly faster, with 4.7 days of vent time versus an average of 8.2 days. And this was a small group, it was 100 patients, and the patients that were allocated to the pressure trigger arm actually had a much higher mortality rate. And so probably there was a pretty big selection bias in actually getting those two groups. And so it's hard to interpret that data. But again, important to know about triggers and understand when they may be useful or not useful for your patients. One thing that I apologize for, I forgot to mention in initially discussing these pressure triggers too, is that pressure triggers can be particularly problematic for patients who are prone to hyperdynamic inflation. So patients with asthma or COPD who sometimes trap air, because when they do that, it gets even harder for them to get their end expiratory pressure down below PEEP to whatever that level is that you set. So they might be a patient who does better with a flow trigger. To talk briefly about PEEP, I think we're all fairly familiar with this concept of positive end expiratory pressure, but to dial in a little bit on what it's actually doing physiologically, thinking back to our mechanisms of hypoxemia, I think we know that PEEP is helping to stent open alveoli and recruit vulnerable alveoli, keeping them open and helping maintain a form of ventilator-induced lung injury known as atalic trauma. But what PEEP is also doing by applying that positive pressure into the alveoli, it's helping to improve the transpulmonary pressure, and that is the pressure across the alveolar wall. And that is a driving pressure that helps keep alveoli open and helps prevent the lungs from collapsing. And so when you're doing this and you're optimizing the alveolar volume, you are reducing your interpulmonary shunting and you're reducing your shunt fraction. And so that is how you're actually improving oxygenation. It's also helpful that when you're applying PEEP and popping those airways back open, you're improving the compliance of your respiratory system. And then this helps you not have to work quite so hard to deliver a breath, regardless of which mode that you choose. I will say that I did spend a lot of time trying to read about what PEEP is best. The short answer is optimizing it still remains controversial. We know that for patients without ARDS or states with significantly impaired compliance, we usually start with a pretty low PEEP, like 3 to 5 centimeters of water. But then trying to figure out when to use a higher PEEP can sometimes be a little bit challenging. Some of the earlier ARDS-NETs studies used higher PEEP ladders, but then some of the later ones used higher and lower PEEPs and really didn't find a mortality benefit with one versus the other. The most recent sort of larger study that addressed this question that I could find was a meta-analysis published by ATS in 2017. And their conclusion essentially was you should not, for a randomly selected patient with ARDS automatically assume that you should give them high PEEP because it may not be helpful and it may be harmful. But they thought through looking over multiple studies that there may be a benefit to a higher use of PEEP in people who have more severe ARDS and who therefore have a higher proportion of alveoli that you could recruit and reopen up with that PEEP. And then what also follows is they said there may be less benefit of using a higher PEEP in people with less severe ARDS and with a smaller proportion of alveoli that you would be re-recruiting. Finally, I'll touch quickly on the FiO2, which again is something that we set in all of our modes. I hear a lot about, when I'm on the unit, we don't want to get to a toxic FiO2 level. And so I was trying to find some data about studies showing the relationship between a certain level and some of the toxicities. I wasn't able to find that much, unfortunately, but I did find some older data which suggested that at higher FiO2 levels, getting into the 50 to 60 range or higher, they could measure decreased vital capacity. Again, that was really old, it's from 1990. But then there are a lot of other sort of reviews that just didn't spell out clear data to me, but sort of anecdotally, they said at levels above 50 to 60, we start to see increased risks of oxygen toxicity. And so I do think that's important to name because I think in the unit, we're so concerned with preventing hypoxia, but we also have to pay attention to hyperoxia. And so often when we turn the vent on, we'll just start it at FiO2 of 100%, but we should be dialing that back down to not over-oxygenate our patients. Essentially, oxygen is an unstable molecule, and so you can essentially have free radical formation, which can produce a lot of damage to your tissues. And there can also be non-free radical mediated damage just through hyperoxia affecting cellular metabolism. So what I've done here is just summarized the main similarities and differences between volume and pressure assist. Again, just to briefly summarize, volume assist tends to be the mode that we use most at UW. You are setting your tidal volume, you are setting your respiratory rate, so you're setting your minute ventilation, and you're essentially monitoring, the gases that we monitor for everyone, and you're also monitoring pressures because you're delivering a set volume in every breath. And so you want to make sure that as the compliance of the patient's respiratory system is changing, it's not causing pressures that are too high. Pressure control, on the other hand, you are setting that driving pressure, you're setting that inspiratory time, you're setting that respiratory rate. In doing so, you're essentially setting up that inspiratory to expiratory ratio. With this mode, you're not getting a guaranteed tidal volume with every breath. It's going to vary, and you're not going to get a guaranteed minute ventilation either. So those patients, if you're kind of maxing out the pressures and they're still not getting the volumes you want, you may have to accept a degree of hypoventilation. I will say that there are a whole bunch of other modes of ventilation. I'm not going to talk about these today, but I've included these in a slide that you guys are welcome to read at your leisure. These are some of the other common modes that I saw in my reading. And so I kind of dropped those there. And I explained them in kind of layman's terms because I frankly don't understand them that well. And so hopefully that is helpful for you. What I want to move on to now is thinking a little bit about troubleshooting and some of the adjunctive measures that we use for our patients who are vented. And this part will be a little bit more participatory. There are some questions as well that will require collecting an answer. The first thing that I want to comment on is alarms. We hear them go off all the time. It's usually going off for the limit that we set, which is, again, you're telling the vent what parameter can you not exceed. In most of our vents, we set pressure as the limit. And most often these are going off just because patients are coughing, they're increasing their intra-abdominal pressure, which is in turn increasing their intrathoracic pressure, causing high pressure in the alarm sounds. But if that alarm is continuing to sound and you don't think that your patient is just coughing and that's why, you can perform an inspiratory hold to try to ascertain, is this the problem of airway resistance or is this the problem of change in compliance of my respiratory system? And the really important caveat to this that I did not initially appreciate is that you can only interpret this if the patient is riding the vent. If there's vent desynchrony or they're not just receiving the breaths and breathing with the vent, you cannot interpret these curves. But what you essentially do, it's just a button on the vent. The patient takes a breath in, you essentially close the flow valve so no air can go in or out at the end of the inspiration, and then you generate this pressure curve. And so what you can appreciate here is that the patient starts at PEEP, the breath goes in and their pressure comes up. This is a volume control mode because the pressure is not constant. And then you perform your hold. And what you see here between the peak inspiratory pressure at the top of the curve and the plateau pressure, which is that flat line, that is where pressure equilibrates across the airways. So the pressure in the upper airways equilibrates with the pressure in the alveoli, and it becomes uniform throughout. And so then once you do that and you've stopped airflow, you remove the component of pressure that is driven by resistance of your airways. So that's what this diagram is saying. That little change in pressure that you can see represents pressure from resistance in your airways. The other piece that this diagram shows you is that between your plateau pressure and your PEEP, that pressure difference is the pressure generated by the compliance of your system. Normally, compliance in folks is 100 or so, again, defined as change in volume over change in pressure. For a patient who's put on a ventilator, it drops to about 70 to 80. Often in our patients who have bad ARDS or bad pulmonary edema, their compliance is going to drop even further and going to be, sometimes as low as 30, 20, looking pretty poor. And so if you generate this end inspiratory hold and you see both a high peak inspiratory pressure and a high plateau pressure, that means that your compliance has gotten worse. And so things that can drive this, perhaps the ET tube has been pushed further into the patient's airways and now you've performed a main stem intubation. Perhaps there has been lobar or lung collapse. Perhaps there is new pulmonary edema. The patient has a pneumo, has worsening inflammation, turning into ARDS. Those are some of the things that can cause worsening compliance of your system. If, however, you have a high peak inspiratory pressure but a low plateau pressure, that means that the resistance of your system has gotten high. And often what is causing this is bronchospasm, in which you need to give them bronchodilators, or a mucus plugging, which you can take care of with suctioning. Other things that can do it, if you have kinked your ET tube, you just need to unkink it, or sometimes patients may just have high airway resistance because their tube is too narrow and you need to swap it out for a wider tube. I think a page that we very commonly get is that the patient is, quote, auto-peeping. And what this means, I've included scalars at the right to hopefully help demonstrate this. Essentially, they are not able to exhale all of the air at the end of their breath. And so they're holding on to a little bit of volume and at the end of the first breath. And then they get another breath. And then again, they can't exhale all of that. And so they're slowly increasing the amount of volume in their lungs at the end of each breath, which in turn is slowly increasing their positive end expiratory pressure at the end of each breath. And so what you can appreciate here on the right, I think if you look at the flow waveform first, we are in a pressure control mode with a decel waveform for flow. You can see the inspiratory limb of the flow that is above the x-axis, and then the breath is delivered. You see that line deflect and flip negatively, and then you can follow that and see that the patient is exhaling. And what I hope you can appreciate is that as you follow that flow curve through the exhalation below the x-axis, before the flow gets to zero, the patient actually starts getting another breath. And so that is one sign that the patient is auto-peeping. You can also appreciate this if you look at the other scalars included here. You can look at the volume curve, which is on the bottom, and see that the volumes are getting progressively higher. And if you look at the pressure curve on the top, you can also see that the PEEP, which is that bottom horizontal line, is getting progressively higher as well. But if you're looking at the scalars feeling a little uncertain that you're able to look at them or interpret them in real time correctly, you can also perform an end expiratory hold after the patient has exhaled all of their air, perform a hold, and see what the PEEP is that the machine measures. If that PEEP is higher than the PEEP that you're setting, you know that they are auto-PEEPing. And so often patients will be auto-PEEPing if they have obstructive lung disease, COPD, or asthma. And for those patients, you can try bronchodilators just to open up their airways. Other things that could be helpful, as I said, auto-PEEPing is usually because the patient does not have sufficient time to exhale that breath before the next breath comes in. And so ways to target that are by 1, decreasing your respiratory rate. 2, if you're in pressure control mode, you can decrease the inspiratory to expiratory ratio, so you can give them more time to expire. Or if you're in a volume control mode, you can increase the flow rate. That helps kind of target that air hunger. As I said earlier, you can also think about changing the waveform for your flow from a D cell to a square waveform. The square waveform delivers the breath more quickly in a shorter amount of time. And on top of all of these things, you also want to be making sure that you're taking care of sedation, agitation, and pain, et cetera, the sort of things that can just perhaps increase your respiratory rate. And we do want to address this because auto-PEEPing can increase the patient's work of breathing. It can increase their pressures and increase their risk of barotrauma. And if we don't correct it and sort of let it get to its end stages, you're going to slowly increase your intrathoracic pressures, and eventually that will impair preload and venous return to the right heart. And so that can eventually cause hemodynamic collapse, which is definitely not our goal when we are trying to take care of these patients in the unit. In addition, I think, to often getting pages about auto-PEEPing and what do we want to do, we do get pages about, hey, here's their gas. Do you want to make any changes to the vent? I spent a lot of time trying to read and find, is there a unified guideline that says what O2s that we should be targeting? And the answer to that is no. I think what I have appreciated is that the goal O2 sought is probably disease dependent. General guidelines that I found, I think we all are fairly familiar with, just sort of suggest a gas oxygen of 55 to 70 or a SAT of 88 to 94. But it's still an active area of research trying to figure out what the right oxygen saturation is. A couple of trials that came up pretty recently, there was the LOGO-2 trial, which they randomized ARDS patients to a conservative oxygenation group where they aimed for a SAT of 88 to 92, and a liberal oxygenation group where they aimed for a SAT of 96 or better. And they had to actually stop that trial early because of safety concerns, and patients in the conservative oxygen group had a rate of all-cause death at 28 days of 34% versus 26%. So they had to stop that early for futility and safety. But ICU-ROX was another trial that came out right around the same time. Of note, they looked at mechanically ventilated patients in the ICU, not just ARDS patients. However, they then randomized them to similar conservative versus liberal strategies and found no difference in mortality. So it's, again, not entirely clear what the goal O2 is. I think the goal CO2 can be easier. I think often we target normocapnia. We in the ICU do allow for a little bit of permissive hypercapnia if needed. We just want to keep the pH at 7.3 or better. And then to change these parameters, as we've been discussing, to change your oxygen, you're thinking about changing your PEEP, you're thinking about changing your FiO2, and to change your CO2, you want to change your minute ventilation. Often we have set a tidal volume that we are happy with and don't want to play with, particularly in ARDS patients where we want lower tidal volumes to help protect their lungs. And so we often will change the respiratory rate. And so I've left a formula here that can be pretty helpful where you just plug in the current rest rate and current CO2 on your gas and plug in the CO2 that you want on your next gas, and that will give you the respiratory rate that you should be changing on the vent. And so this is now an opportunity for the listeners to participate. This is a question from Mix App, and so I will read it. We have a 34-year-old male who is hospitalized for acute respiratory failure following a heroin overdose and aspiration Current meds are pip/tazo, propofol, heparin, and Pantope. On exam, he has a temp of 37.7, BP of 114/77, pulse of 74, and rest rate of 16. His ideal body weight is 63 kilograms. Vent settings, he's in volume controlled mode with a tidal volume of 630, PEEP of 8, and FiO2 of 0.5. An ABG on FiO2 of 0.5 shows a pH 7.33, a CO2 of 46, and an O2 of 76, and chest x-ray shows bilateral opacities. So which of the following is the most appropriate next step? Decrease your PEEP, increase your PEEP, increase your respiration rate, or reduce your tidal volume. Give everyone a few more seconds. Okay, Lauren, do you end the polling? I don't know how to do it.
Yeah, people are still voting. Give them 5 more seconds.
Okay, great. And so it looks like there was a little bit of choice for all of them, with the majority of participants suggesting that we should reduce the tidal volume. And so that is the correct answer, is to reduce the tidal volume to help avoid ventilator-induced lung injury. As I mentioned earlier, the ARMA trial is one of the earlier ARDS-NETs trial, and they compared low tidal volume ventilation, 4 to 6 mils per kg versus 12 mils per kg, which was standard of care at that time, in patients who have ARDS, and they saw a 9% reduction in mortality. And so for this patient we have in this question, he does have ARDS with the acuity of his lung injury, his bilateral opacities on his chest radiograph, and a poor P to F ratio. And so we want to reduce his tidal volume to adopt lung protection ventilation, which will help hopefully reduce his mortality risk. When I was reading about ventilator-induced lung injuries, I thought it was interesting. Earlier, we used to think that pressures were the biggest driver of vent-induced lung injury, but we've actually come to realize that volume tends to be the biggest driver of damage. There was a study that really changed the way that people thought, published in the late 80s. It's actually an animal study where they vented rats and essentially found that the risk of pulmonary edema was higher only with high volume, and it didn't matter what inflation pressure that they used. They then did some pathologic analysis and saw that this was not just a watery sort of pulmonary edema, but actually an edema that was very inflammatory and resembled ARDS. So volume associated lung injury is really the thing that we're trying to minimize when we're keeping tidal volumes low in LPV. That is not to say that there are not other types of trauma from the vent. Barotrauma is something that we can still see with pneumos, with pneumomediastinum, pneumoperitoneum, things like that. But volume in my reading actually was the biggest thing that we pay attention to. This is a case that is not an exact question, but this is a case that was published by Dr. Lux and Dr. Cora in ATS a few years ago. I think they saw this patient at Harborview. She was a 52-year-old female who presented with a left lower lobe pneumonia, which you can appreciate here on this chest radiograph. Her initial vent settings, she was on volume control with a rest rate of 20, tidal volume of 8, PEEP of 10, and FiO2 of 1, and she was starting at 90%. The PEEP was increased from 10 to 20, and her O2 sat dropped. She became more hypotensive, and her mixed venous went from 60 to 40%. And so in reflecting on what happened here, this case actually demonstrates the sometimes harmful effects of PEEP. What happened for this patient is that the PEEP paradoxically worsened her oxygenation. What happened was that the increased pressure in her alveoli wound up causing distension of the alveolus, but then that actually squished all of the little blood vessels that are in the alveolar walls. And that caused the blood flow to redistribute to other areas of the lung that were not as well ventilated. And so she essentially had worsened VQ mismatch and intrapulmonary shunting, and then had more hypoxia as a result. What also happened for her is that the PEEP got so high that she had increased intrathoracic pressure, which dropped her venous return to her right heart, dropped her cardiac output. And so with her decreased cardiac output, what her tissues then did was that they increased their extraction of oxygen in the periphery. And so that is why her mixed venous O2 was then lower. So ultimately what they did for her, they put her on pressors and they pulled the PEEP back down, and within a matter of hours, her oxygenation had improved and she was off of pressors. But I think this is a particularly striking example of how PEEP can sometimes be harmful. We think of it as something to improve oxygenation, but we have to be careful with it, particularly in patients with focal processes, because when we apply it, we can worsen their VQ mismatch as we push more blood flow to that focal opacity. I will just briefly mention this because we see it sometimes. We can use in patients who are trying to figure out their PEEP esophageal balloons. Essentially, we have some patients who have poor chest wall compliance, they're obese, they have a lot of intra-abdominal pressure, and we're trying to figure out, hey, is that pressure that we're seeing on the vent because of their chest wall compliance issues, because their belly is pushing up on their lungs, or is it because of something else? And the esophageal balloon, I'm not going to explain in detail, but it helps us figure out the contributions of compliance from the lungs specifically so that we can better optimize their PEEP. And you can read more about it if you would like. Of note, there is no demonstrated mortality benefit or difference in ventilator-free days. And so the benefit of this is not entirely clear, but I have sometimes seen it used in patients who are obese, and we're trying to figure out, is this higher PEEP that we think we're using to combat their belly pressure safe? This is another mix-up question that I'll have you guys shout an answer to. And I recognize that we are getting short on time, so I'll try to wrap up in a couple of minutes. This is a 62-year-old man who's admitted 12 hours ago with ARDS. Overnight, he developed fever and increasing respiratory distress, was intubated, and had rapidly increasing vent requirements. Current vent settings are volume controlled, and he's receiving appropriate low tidal volume ventilation. He's on fentanyl, midaz, heparin, zosyn, and norepi. On exam, his temp is 38.4, BP is 89/45, pulse is 110, and his spontaneous rest rate is 35 with a PEEP of 16 and an FiO2 of 1. His gas shows a pH of 7.3, a CO2 of 51, and an oxygen of 55. Chest radiograph shows diffuse bilateral opacities throughout the lung fields. Which of the following is the most appropriate management? Perform a recruitment maneuver, start inhaled nitric oxide, transition the patient to high frequency oscillator ventilation, or ventilate the patient in the prone position.
There are a couple of seconds to finish up voting.
Great, okay. So it looks like a couple of folks thought about performing a recruitment maneuver, and the overwhelming percentage of votes was for ventilating the patient in the prone position. And so the correct answer to this question is to ventilate the patient in the prone position. To talk briefly about why we would not perform a recruitment maneuver in this patient, when we perform a recruitment maneuver, we are increasing the positive pressure that we apply into the airways. For a patient who is quite hypotensive, we want to avoid this because it could cause further hemodynamic compromise. However, proning is something that we are starting to do more in the units. And what I've been reading a lot is that, there's still sometimes talk about it as a salvage measure or an extra measure, but we should really be thinking about it as part of the standard of care for patients with ARDS, because it is the only thing in addition to LPV that has been shown to improve mortality. And that was demonstrated in the Perceiva trial in 2013. And to highlight the actual protocol that they used, They stabilized their patients for 12 to 24 hours before they proned them, optimized their vent settings. And once they proned them for at least 16 hours consecutive hours, within a 24-hour period. And so if we are going to prone our patients and we only get 8 hours in the day and we feel like it's not working, we don't have data to really know if just doing that 8 hours is effective or not. The only data we have is for at least 16 hours. And to quickly talk about some of the other answer choices, I mentioned that recruitment maneuvers, you apply an increased amount of pressure to the lungs and you're trying to open back up those alveoli, can be scary to do in patients who are already hypotensive because you don't want to further compromise venous return to the heart and cause hemodynamic compromise. There are also a lot of more recent studies that suggest there's really no mortality benefit for recruitment maneuvers. There was not much that I could find in the way of reading that actually suggests a benefit for them. And so I think moving forward, I would probably be having more conversations with my RTs to say, hey, is there actual benefit for this? Or are we just increasing risk of barotrauma, lowering their BP, et cetera? The harms to me seem a little bit scary and the benefit is unclear. Pulmonary vasodilators, on the other hand, also have no mortality benefit, but they can improve your VQ matching. And so I think it's appropriate to think of those as stopgap measures while you're trying to get more definitive management to target whatever is causing the oxygenation problem for patients. There is one more question, but if time is getting a little out of hand, I can just skip to the answer and then that is where I can end. The point of this question is just to essentially, the patient is desynchronous with the vent and it is getting at starting neuromuscular blockade as something to help with vent desynchrony. And so I wanted to just touch on the fact that in older studies, it was thought that neuromuscular blockade, particularly early short-term administration, would improve survival and time off the vent, and it was not thought to increase muscle weakness. However, in more recent studies, particularly in the ROSE trial, which came out 2 years ago now, there was no difference in mortality between patients who were randomized to early short-term neuromuscular blockade versus just standard LPV. And so what I've seen, at least from a lot of the different attendings, is that it seems to be sort of provider dependent if they want to use it for vent asynchrony or not. That seems to be the only indication that people will use it, if any. We now feel that there is not a mortality benefit, but there are some attendings who I've seen will not use it for vent desynchrony because they know that it doesn't affect mortality. So I think this is still something that we're trying to understand a little better. And, over the past 10 years or so, we've developed a lot of new strategies for how to manage vents with better titration of PEEP, introduction of proning, things like that. And I think that can make it a little bit challenging to compare some of the older studies to some of the newer studies. But the role of neuromuscular blockade, I think, is quite controversial. But what we can say confidently is that it really doesn't seem to affect mortality anymore. So other things that you can think about when you're trying to figure out why the patient isn't riding the vent is to essentially just look for things that could be causing distress in the patient. Are they hyperinflating? Are they in pain? Are they agitated? Are they delirious? Thinking about all of those things, or potentially just trying a different mode of ventilation that they might tolerate better. So I here have some take-home points that summarizes a little bit of what I've talked about. I think I included a lot of information. Hopefully some of it was helpful. I'd like to pause here for any questions before I let you guys go about your day.
Thank you, Molly. Thank you, everyone, for coming. If people are thinking of questions, then please feel free to share them. Otherwise, we will see you again next week for another, I think we have another day of president talks, so it should be great.